Good afternoon. Welcome to the second 2014 Prevention Science Series seminar, being sponsored by the American Sexual Health Association and the Division of STD Prevention. It gives me tremendous pleasure to introduce to you Dr. James Blanchard, who's the director of the Center for Global Public Health at the University of Manitoba, who has received his medical training at the University of Manitoba and his public health training at Johns Hopkins University, and who happens to be a person I work very closely with. So I guess he's my collaborator, my mentor, sometimes my mentee, whatever it takes. And he's going to talk about something which he has been very, very instrumental in founding, and that is program science. Jamie.
Thank you, Sevgi, and thank you for inviting me here. And it's a delight to be back and to see some familiar faces and a lot of new faces. I'm very happy to be here speaking about program science, and as Sevgi said, it's something that we've been working on together a fair bit recently, and it's really, in my case, it's been transforming the way I think about my role as an academic and also my role as a public health professional. Now, I've been hearing for the last, I've been hearing for the last while from Sevgi and other colleagues here about the division's new FOA, the Funding Opportunity Announcement. So I was wanting to get a little bit of information about it. It's not easy to find that information on www.grants.gov, I have to say. It's not easy to find a particular announcement. So I typed in the search box, program science, and it was the only funding announcement that came up. And so that's how I found it. And it was interesting because when I looked at it, it helped me to reframe some of the ways we've been thinking about program science, using some of the terminology and the framework that's being utilized by the recent FOA. I can't say that I read the entire FOA, but I think I read enough of it to try to get a sense of it. Anyway, the three sort of key areas identified in the FOA are epidemic assessment, which I've sort of simplified as saying that this is to help understand what should be done. Another interrelated domain that I think is related to program science is the assurance, which relates a lot to how should it be done, how should we do things. And then there's a whole section on policy, but I've added policy and management, and I think this relates to how should this be managed, and managed using a fairly broad way of thinking about management. So in essence, these components of the FOA, I think, map very closely to what we've been doing and what we've been thinking about in relation to program science. And I'll try to illustrate that using predominantly a one-country illustration. I'm going to use an example of work that we've been doing in Nigeria. But to try to illustrate how these three interrelated areas can feed into a more comprehensive and coherent program science approach. So to just break down these three areas a little bit more, what are the key issues in epidemic assessment? So I think the first thing is what is driving the epidemic, or the epidemics if we're thinking about multiple epidemics. And this means that we need to have some knowledge of the transmission dynamics and the phase of the epidemic. And we need to understand what are the important behavior patterns and sexual structure that really are determining the distribution and the trajectory of the epidemic. I think another area that we need to look at more and more is the level and nature of heterogeneity. I think there's been a lot of excellent work by your colleagues here at the CDC who've looked at issues of concentration and geographic and spatial distribution. And I think that increasingly we need to understand and do a better job of describing the geographic variability and also the distribution of key populations and networks as they relate to the epidemic. So I think epidemic assessment has a number of key issues. I've just drawn out a few of these, and I'll try to illustrate these in the examples that follow. Assurance. So under assurance, I think this really relates to what are the key prevention objectives and what are the intervention components. And you can break down the intervention components in a number of different ways. Some people are now talking at some levels about behavioral, biomedical, and structural intervention components. But there's different ways of thinking about it. But when we talk about assurance, we're really talking about what are the elements of the program, what are the core elements. Some people might call them practice guidelines or public health guidelines. But in any case, assurance really relates to the idea of making sure that we understand what are the components of our interventions and what are the standards to which we, and then how will we assure that those are being delivered for the population. And so that relates to the standards and guidelines that should be promoted by subpopulation and component of the intervention, and also with a clear specification of the expected results and indicators. So what is it that we're trying to achieve and how will we measure it with respect to these intervention components? And then policy management, I think, is too often neglected, but it clearly has an overarching influence on the success of programs. And I've just identified a few areas that I think are important to consider in the area of policy management. First, what are the levels of responsibility and distribution of roles? We might know this intuitively, but we sometimes don't think of it explicitly. So at the macro level, how is resource allocation and establishing the program footprint decided? Who decides that? How does it get decided? What are the policy levers? What are the management structures that make those decisions? What are the implementation and service delivery processes? Who implements what? How is service delivered? Is it through private system? Is it through public system, et cetera? How will programs be scaled up? What are the systems? How do we systematically analyze and fill gaps in programs? How do we also look at the resource allocation and human resource plans and how that fits with the footprint of our program? And then I think another area which I think is really central to program science is how will the program learn and adapt? A lot of programs are well designed and they're implementing their mandate, but they don't have inbuilt mechanisms for ongoing program-related research, problem solving, and quality assurance. So those components, I think, unless they're incorporated in, you don't have a well-managed program. A well-managed program is a program that's learning and adapting as experience is generated through the program activities. So these are three sort of basic and main domains, and I'm going to try to illustrate how some of them are being operationalized at a country level with a fairly complex country program. So in Nigeria, just over the last 2 years, we've established an integrated program science initiative, and I'll try to explain what I mean by that. First of all, why Nigeria? It contributes the second highest number of new HIV infections globally, and it has a host of other issues. We don't even really know what the scope of the STI epidemic is there. There has been enormous investments in Nigeria from the U.S. government, GFACM, World Bank, the United Kingdom. I heard a figure within the last 2 or 3 months that PEPFAR and the U.S. government has contributed $6 billion for HIV prevention in Nigeria alone over the years. So it's a huge investment. There's an enormous investment in Nigeria for HIV prevention, which accords to its importance in the global epidemic. Most of the funding has been for threaded, targeted programs. Huge amount of money going into HIV counseling and testing and scaling up HIV counseling and testing. Enormous resources are going to treatment, care, and support. Big investments in PNCCP. And as you can see, these are all sort of threaded, non-integrated interventions, but they're being invested in at a massive scale, and they're not necessarily well coordinated. So there's a concerted national effort in Nigeria to try to coordinate prevention and come up with a more overarching national prevention plan. And this is the context in which we're trying to introduce some of these principles around program science. So, going back to this framework, in Nigeria, what we're trying to do is we're trying to incorporate epidemic assessment with processes around assurance, and also improving the capacity and the processes for policy management. And I'll try to illustrate how this is being done at that level. So those of you who aren't familiar with the epidemic and the HIV epidemic in Nigeria, it's very heterogeneous. It has some states with prevalence well over 10%, and have persistently had prevalence over 10%, but it has some areas that have prevalence of less than 1%. So it's a very heterogeneous. It's not a single epidemic, it's multiple epidemics. One of the remarkable things about the epidemic in Nigeria is it's one of the few epidemics that has reached this level of severity with prevalence over 10% in a fully circumcised population. So essentially the Nigerian population is almost, is more than 90% circumcised. And so we see a lot of extensive epidemics in sub-Saharan Africa, but mostly in places where there's a lack of circumcision. So the Nigerian epidemic is happening despite high levels of circumcision, and very advanced epidemics are there even though there's very high levels of circumcision. When we think about the Nigerian epidemic, it probably is best characterized as a mixed epidemic, meaning that it has elements of most at-risk populations that are contributing to the epidemic, but it likely has networks that are also contributing that are beyond the definable risk groups. And so really the challenge here is to get the mix of interventions right in according to the mix of the epidemics, and trying to do this within the challenge of a very, very heterogeneous epidemic. There's been an enormous amount of research and a lot of surveillance has been done in Nigeria. There's a whole compendium of various types of epidemiological, behavioral, other kinds of research that's been done in Nigeria. The World Bank had a project with the National Agency for the Control of AIDS there to try to assemble all of the research and great literature that was there, and it's truly a large volume of research that's been there. Most of it is not very informative about the sexual structure and networking. They're individual behavioral studies, but they don't get into the details about how the different groups relate in terms of sexual networks. There's been very little differentiation between urban and rural contexts, particularly at the national scale. There's been almost a complete lack of information about the size and distribution of key populations, the most at-risk populations like sex workers and drug users and high-risk MSM. And the information was at a level that was either too low or too high for translation easily into prevention plans. So there'd be an individual study at a clinic or an individual study within a smaller catchment area on behaviors or STI or HIV prevalence, but not necessarily matching with the scale at which you plan your program. So it was difficult to assimilate and translate the existing data into a program framework, because it was done generally for research purposes. Much of it was done for research purposes, and it wasn't necessarily done at the scale at which programs are being designed. Similarly, the national surveillance was done to get national pictures, or maybe even state pictures, but it's too heterogeneous a country, and the states are too heterogeneous to be able to use that information for differentiating program responses. So it was difficult to get the information aligned with the levels at which program planning and implementation. And as I'll point out later, there were real concerns about the accuracy of the behavioral data. So the behavioral data was generally collected through routine population-based health surveys, through face-to-face interviews, and the levels of risk behavior that were being reported didn't really comport with a generalized epidemic, particularly a generalized epidemic or a high level of epidemic in a fully circumcised population. So there was a mismatch between what we were learning about the behaviors and the behavioral patterns and what the epidemic was looking like. And there was no match between the behavioral data and the level of the epidemic if you tried to match them ecologically. So a state with very low prevalence had the same sexual behaviors as a state with very high prevalence. So it was very difficult to understand what was going on in that relation. So one of the first things that we did was we tried to think about the information, the assessment information that would be useful for planning programs. And so we started with a fairly simplified rubric or framework that segmented the population along the lines of how a program would be designed, rather than along the lines of how a researcher would necessarily think about it. So what we wanted to do is we wanted to get information that would allow us to have information about the most at-risk populations, information about other urban populations that are not MARPs but may be interacting with MARPs, and general population, in this case, looking at the rural segment, the rural population. So when we met with program people, they were thinking about this. What do we do for the MARPs? What do we do for other prevention needs in urban areas? And what do we do in the rural areas? And so the epidemic assessment really had to give information that could feed directly into how they would plan these segments of their program, because logically that's how their program logic was: targeted interventions for the MARPs, other urban interventions, and then how are they going to tackle the rural epidemic. So we developed with them an epidemic appraisal approach that really looked at three different domains. One was MARPs, to understand the location, size, and typology of MARPs, which we did through geographic mapping. I'll be presenting some of the results. Other vulnerable populations in the urban areas, to try to understand the nature and size of the casual sexual networks and focusing on the headquarters of their local government authorities. And here we used a modification of Sharon Weir's place method. So we tried to apply this in a way that could be done in all of the headquarters, in LGA headquarters of a state. And then for the general population, we wanted to understand what was the prevalence of risks for HIV in the general population, but also to understand a little bit more the contextual factors associated with variability of HIV risk in the rural areas. And for this, we did two things. We did rapid village profiles, so profiling villages, not as individuals, but then as aggregates as well. And then also we did rapid behavioral surveys to get a sense of the sexual structure and differences in sexual structure and behavior within the rural areas, using methodologies that could be done on a very large scale and done very quickly. And so I'll now present to you some of the results that we have from this. So the first thing we did was we did mapping of the MARPs, and we did mapping, and the mapping is now being done in a standardized fashion in all of the states. So even though many of the states are being have interventions from different funders, all of the funding organizations have agreed to use a similar mapping methodology. This is the results from the first 7 states that were mapped, and you can see that the number of sex workers ranges from about 47,000 in Lagos to about 6,000 in a number of states. And so this is the first sort of clear information that they had that helped them understand the scope of the problem, that allowed them to say, well, if we're going to do a female sex worker program, what would be the required scope? In addition to the estimates, the methodology gave them specific spots. So in each of these locations, there were all of the hot spots were identified. So they not only have the estimates, the implementers and the planners have spot maps of all of the different places where there's brothels or street-based sex workers or others. So it's a massive amount of information, but it's finely grained enough that if you're working in a town or a city, you can say, well, there's this many sex workers, there's this many brothels, there's this many other kinds of locations where they work, so that they can have not only an overall estimate for the resource requirements, but also they have the spot mapping to allow them to say where they're going to intervene and what they're going to focus on. We did the same thing for injecting drug users, and this gives the estimates of the number of drug users, and we did the same thing for male sex workers and other high-risk MSM. So that was defined as MSM who were going to cruising spots or bars or other locations to meet new sexual partners. So this is not the entire MSM population, or likely not even the entire male sex worker population. But what we did is we tried to map the places where male sex workers and other high-risk MSM were congregating to meet new partners, thinking about venues and networking spots. And this is an illustration. So the states now have a full picture of these 3 most at-risk populations in terms of the size, distribution, and the typologies. Are they street-based? Are they are they in different venues, hotels, etc. So it allows them to now develop a coherent MARPS response plan that is based on information that they collect. I should say that these assessments were actually done by the state agencies for the control of AIDS. And so our role was really in helping them develop the methodology and training them, and then supervising some of their field teams as they were doing this work. So there's a high level of buy-in by them to do this, and they paid for it. The second thing that we did was we tried to understand what's going on in the urban areas, and this has always been a bit of a conundrum: is how do you plan a program in an urban area beyond MARPS? And a lot of their programs said, well, we're going to work on out-of-school youth or college students, or they had a whole list of demographies or occupations that they were going to deal with, without really having a sense of how many they were going to reach or why they were reaching them. Policemen were always part of the thing, even though the prevalence among policemen is lower than the rest of the population. But they always sort of dealt with urban populations by listing out who were perceived to be at higher risk. So what we did was we leveraging the experience and the fantastic work that Sharon Weir's done on developing PLACE, we modified it to be applicable at a very large scale, so that you could rapidly map venues, not get as much detailed information, but get the basic information about, is this a place where people are coming to meet sexual partners? If so, who's coming there? If so, how many people are coming? And not going into a lot of details about how many sexual partners each person had, but really trying to map and profile the venue rather than too much information about the individuals within the venue. And this we did on a very large scale. We got information like this. So this was again done in all of the states. It's being done now across Nigeria. But basically, they were the kind of information we got is, where do males who are seeking females as new sexual partners, where do they congregate? So we found that it's mostly in bars and clubs, some restaurants. There's a host of other places. And this was differentiated by state. In some states, it was mostly the public markets where they were meeting. In other places, it was mostly the hotels. In other places, it was bars and clubs. So this kind of information was available now for each of the states, that they could know, where do people meet new casual partners. We also found out at these venues what percentage of the patrons who are visiting these venues are seeking sexual partners. So for example, if you look at Lagos or Benue, in the venues that were profiled, more than 35% of all of the patrons that were visiting these venues were seeking new sexual partners. So these are very high-risk kind of contexts. In contrast, in Anambra and Ondo, less than 20% of the people visiting these venues. So you got a sense of how concentrated your investment would be if you worked in these kinds of venues. And this was again differentiated by venue type. So if you go to this kind of a venue, you're more likely to get a high percentage of people who are meeting new sexual partners. If you go to that kind of a venue, you get much fewer people. So for example, restaurants were, turned out to be very low level of people seeking casual partners, whereas bars and clubs naturally were much more so. But this was quantified for the state, so that when they're thinking about a strategy of where are they going to reach people who are seeking out casual partnerships in an urban area, where should they go? And if they go there, how many people will they reach? And that, I think, was an important thing for them for planning. The other thing that we thought was important was to see how much overlapping is there between the higher risk networks and the more casual networks. So we wanted to understand, there are some venues that have only sex workers. There are some venues that have sex workers plus people who are looking for casual partnerships. And there's some venues where there's no sex workers, but people go there to seek casual partnerships. So what we wanted to do in each of the places is see how much overlap is there between, at a venue level, between venues that have sex workers and venues where people are just seeking casual partnerships, with the understanding that if you're wanting to focus on the more casual sex network, you would again probably want to prioritize the places that also had female sex workers, because you would have an intersection of those networks. So for example, in Lagos, 80% of the venues had sex workers, and only 20% of the venues had only casual networking. So there's a very high level of overlap. In contrast, a place like Benue, less than 65% of the venues had sex workers, and more than 35% of the venues had only casual networking. So you wouldn't get as much of a concentration of the casual network if you focused on only the sex work venues in Benue, which made sense to the people there. They said there are a lot more casual sex places without sex workers in Benue state. So this sort of summarizes that if you look overall, if you looked overall in Benue state, for example, if you focus just on female sex worker venues, you could reach about 53% of the people who are seeking casual partners. But to get the other 47%, you'd have to focus on other types of venues. So you couldn't just focus on sex worker venues. Whereas in Abuja, the capital, if you focus just on the female sex worker venues, you could get also about 80% of the casual networking venues. So there's a much greater overlap in Abuja than there was in Benue. And so this strategically was important for them to differentiate. The other thing we did is we looked at the volume of patrons. So if you're looking at coverage, we wanted them to think through what would be your coverage if you covered different types of venues. So, for example, if in Benue, if you covered just Zone 2, we zoned the state. If you covered just Zone 2 and focused only on the venues where there's casual networking, you cover about 40% of the people who are seeking new sexual partners. If you added in the Zone 2 female sex worker venues, or the venues that have sex workers, you would cover about 60% and so on. So by covering 3 zones and 3 different types of venues, you could get over 80% of the estimated number of people who on a typical night would be out seeking sexual partners. So the idea again here was to give a macro level picture that allowed them to say where is it that they should concentrate their prevention resources. And I should say, well, I'll mention it later, but basically this is the kind of information that they're now feeding into their prevention plans at a state level. The third area that we looked at in our epidemic appraisals was looking at the rural situation and assessing the sexual structure in rural populations. And again, what we did here is we looked at profiling the villages. So this was a very rapid thing to understand what's the size of the village, what's happening in the village, are there sex workers in the village, are there a lot of people living with HIV in the village. So this was basically a rapid sort of assessment of the village by interviewing 15 or 20 key informants, who, including at least one member of a key population within a village. And so this was done as a very rapid activity because we were covering all of the villages. And then we also did some polling booth surveys to get at the sexual behavior, and I'll illustrate that. So as an example, if we look at the percentage of villages who were reporting any PLHIV, so we would interview health workers and other people within a village, and we would try to find out, is there anybody living with HIV, and then we would try to get estimates. So a place like Benue with a prevalence of over 12%, basically 100% in 100% of the villages, people said they're living with HIV. In Ondo, where the prevalence is less than 1%, it was less than about 35% of the villages did people say that there are people living with HIV. So this really comported with what we were getting in some of the prevalent surveys, but now it was focused down at the village level. We also asked about whether there were any female sex workers living and working in the villages. So this just shows you that in Benue, as an example, in about 90% of the villages, people said that there were sex workers who were living in the villages, compared to Ondo and other places where less than 40% of the villages were there sex workers living there. We had estimates of the number of sex workers in each of the villages. The third area, so that just gives you an example of the kind of information we got about villages. Again, it was to try to give the program a sense of how could they target their rural prevention programs. Where does it look like there's a high burden of HIV? Where do they find high-risk populations in the rural areas? And the third thing that we did was we tried to get behavioral data that was finely grained enough to allow you to look at the rural population and to look at zones within a state. And the second thing that we wanted to do is to use methodologies that might reduce the social desirability bias, because we were very concerned about previous surveys that had essentially found very few people engaging in any kind of high-risk behavior. So we used a method that's been developed called polling blue surveys, which is an anonymized way of people responding to yes-no questions about their sexual behavior. So in each of the villages, what we did is we got 6 segments of the population randomly selected, or as randomly as possible selected from within the village. So we had unmarried and married men and women of 3 different ages. And that's how we got our 6 groupings. So we don't have individual information about them, but we know their age and we know whether they're married or unmarried. And you can see the sample sizes were pretty big in each of these states, several thousand or a few thousand in each of the states. So this is an example of the kind of information that we received. So if you look at unmarried males as an example, whether they've ever had sex with a sex worker, about 37% of males in Benue said that they had ever had, and about 17.5% said that they'd had sex with a sex worker within the last month. And this was, Nasarawa was much lower, and so on. So this was the kind of information that was available to us. We also asked about non-commercial partners. So this is these are data on the number of people who reported, or the proportion of people who reported more than one sex partner in the past 6 months. And this is just looking at married and unmarried females. You can see, for example, in Benue that 35% of the married women said that they'd had more than one sexual partner within the last 6 months. And if any of you have seen any of the population surveys in Nigeria, this is much, much higher levels of risk being reported than you'll see in the face-to-face interviews, the DHS surveys, et cetera. We also asked about things like transactional sex. So you can see, for example, that in Benue and Cross River, about 45% of unmarried females said that they had transactional sex in the past 6 months. So again, very high levels of risk behavior, particularly higher than what we had seen previously among females, but also differentiated between the states. We could see big differences between states, and we could see big differences within states in terms of these behaviors. And in fact, I just as an illustration, comparing 2 states here, you can kind of see that the data comports with what the epidemiology had been telling us, which is something that we hadn't seen before. So the HIV prevalence in Benue State is estimated to be 12.6%. This is based on the latest ANC surveys. I think it's been about 10% in the general population survey. Ondo State, the ANC prevalence is 2.3%, less than 1% in the general population surveys. So the number of female sex workers in the urban areas was around the same, 10,000. But the percentage of patrons visiting social venues seeking sexual partners in urban areas was much higher in Benue than in Ondo State, so 38% compared to 18%. The percentage of villages reporting any persons living with HIV was about 100% in Benue, and it was about 35% in Ondo State. The percent of villages reporting any sex workers was 90% in Benue and 36% in Ondo. The percentage of married and unmarried men visiting sex workers in the last month in rural areas was 8 and 18% in Benue and 12 and 15% in Ondo. There's an interesting explanation for this. And then we looked at the percentage, and I think this is really the most important feature of the data. It's the percentage of married and unmarried females with more than one sex partner in the last 6 months was 35% for married and 47% for unmarried females in Benue, compared to 13 and 22%. We do. It's highly variable, but it's probably not more than 50% in most places. Many of them were formally married, and a lot of the women in sex work were formally married, and they're not married anymore. But one of the things I wanted to point out is that previous surveys had estimated that in Ondo State had estimated that 0.2% of women had multiple partners, and 0.3% of men had ever paid for sex in Ondo. That was the data from the DHS survey, but we saw that continuously, that the data that was that was being relied on, we just couldn't see any differentiation, and we didn't see any sort of high levels of risk behavior. And so we think that these polling booth surveys not only gave us rapid information, but it was giving us more authentic information about the level of risk. Certainly, if you're going to get to 12.5% in a fully circumcised population, you have to see these levels of risk behavior. Otherwise, it's hard to explain. So how are we using these epidemic assessments? So these epidemic assessments are done at the state level, but they're done in enough places that it allows them to look at all of their LGA headquarters, so all of the major towns and cities, and also for the rural appraisals, they have it now zone by zone by zone. So there's two main areas that these assessments have been used for. One is that they've been used to develop what are being called prevention policy briefs. So these are basically, each state is developing its prevention priorities. Is it focusing on MARPs? Is it focusing on urban? Is it focusing on rural? Which subpopulations is it focusing on? So it's really taking these appraisals and saying, based on this, how are we going to prioritize and allocate our resources? So it's really a policy brief around around prevention at the state level that's informed by the assessment. The second thing that they're doing is they're being used to develop terms of reference for program delivery. So a lot of the program delivery is done through NGOs, but the TORs for the NGOs, so the requests for proposals for the NGOs, are being based on these epidemic assessments. So that the TORs are now very specific about what program components do they want. Is it for MARPs? Is it for other urban populations? Is it for the rural populations? And then what is the geographic focus? So they'll say they want so much concentrated in these zones and these LGAs, et cetera. And then what are their coverage targets? So they're specifying based on the mapping and other population assessments, what are their coverage targets? So the epidemic assessments are not sort of left on their own. They're now explicitly tied into their policy briefs at a state level and then the TORs for their NGOs. So the NGOs are now going to be responding with proposals that meet with the terms of reference which have been driven by these epidemic assessments. I won't spend as much time on the assurance piece, but I think that this is really important. So when we talk about assurance, how are we governing how things are done? And so I think the first thing is that at a national level, there's the redevelopment of a national prevention plan. So the national plan really establishes the overall objectives. What are we trying to achieve by subpopulation? What are we trying to achieve in terms of behavior change, coverage of different components of the program? By what strategy will this be achieved? What are the planning processes? Who's involved? Where is the accountability structures? What are the implementation mechanisms? Who implements? Who pays for it? Those kinds of things. The second area that we're working on with them is on implementation guidelines. So this relates to, if you are going to do a program for most at-risk populations, what are the components? What are the essential components? What are the variable components? What are some of the standards around the delivery of those components? What are some of the human resource standards? Moving down to what are some of the budget standards? So these kinds of things are now being incorporated into guidelines. Similarly, there's an interest in developing some guidelines around how to deal with these venue-based interventions for urban populations. Many are, at this point in time, are adapting and using the PLACE methodology for doing that. And in rural prevention programs, again, developing some guidelines around how do you select and scale up and what are the components of a rural prevention program, particularly how do you combine elements within the rural area. And then I think the third area, which I've alluded to already, is terms of reference for the implementers. So rather than having relatively vague calls for proposals, the idea here is to develop more specific terms of reference so that when potential implementers are making proposals, they're being very specific and they're following along with what's being the guidance that the states have from their epidemic approach. So they're specifying the geographic focus. They're setting coverage targets. They're defining the intervention components. So it's something that the NGOs themselves are not necessarily specifying. It's something that's being that's part of their terms of reference. And there's also a common measurement framework that ties in with this. So how are we going to measure achievement and results, and how will that be done by implementers? I think I'll skip past this. So if we look at policy and management, some of the key issues in Nigeria, and I'm just going to touch on this briefly. I mean, there's a whole host of other issues that I'm not discussing here. But one of the things is leadership and coordination. They are increasingly, I think, pulling together national leadership groups and resource groups and working groups that are really trying to provide some leadership and coordination. But it's very difficult to clarify roles. So what is their role versus the role of somebody who's responsible for the PEPFAR program in Nigeria? What is their role versus the responsibility of the person who's working for CDC in Nigeria? So clarifying these roles and responsibilities and integrating them together at a national level is not simple. But I think increasingly what's happening is it's being organized around a common plan. So different agencies and organizations, funding or technical agencies or organizations, have their role, have their specific functions, but they're being coordinated through a common planning mechanism. Another key area in policy management is I think there's been a real lack of mapping of resources and really not looking at the gaps, what's missing here. So if you look at a state, you may have 3 or 4 different organizations who are providing resources there, but nobody's mapped both what are the resources in the state, but more importantly, what are the gaps? Who's uncovered by this, whether it be a PMCCP program or whether it be a targeted intervention program. But basically, the mapping of resources and gaps hasn't been systematic because it hasn't been clear whose responsibility that is. Is the responsibility of the person who's funding a PMCCP program or the person who's funding a treatment program or a targeted intervention program? Whose responsibility is it to do this? And who has the resources to do that? So increasingly, this idea of systematically mapping the resources and gaps and then making sure that human resource plans are matching your program plans. It's fine to say this is how we're going to organize things, but how is that matching with what your human resources are? And then how are the various providers linked and coordinated? So in many cases, the NGOs can do certain things, but service providers have to do something else. So how do you link and coordinate that? These are things that have to be sorted out at a policy and a management level. And who funds what? Well, who's responsible for funding different components? There's not only coverage gaps, but there's gaps within a cascade of things that need to happen. So somebody will fund these 3 processes. This process is not funded by anybody, and then the next 3 processes are funded by somebody else. So what you do is you get critical gaps in a cascade of things that need to happen in order to maintain consistent and good coverage. And so even just mapping processes and gaps within processes, I think, is a really important management challenge. And I think a final area is capacity and supportive supervision. Do the right people have the right capacity? A lot of times the decision makers don't really have the capacity and they don't have the resources to acquire the information and the resources to make those decisions. And there's a ton of technical assistance that's going in, but where is the supportive supervision and how is it being provided? I'm going to have a very brief presentation on a Ukraine project just to show a little bit of a different dimension, again, using some of these same principles. It's a project in Ukraine. It's a project that we're doing with UNICEF. It's focused on young female sex workers, young injecting drug users, and young street-involved youth. And again, we have a series of assessments, and these assessments are then being converted into a citywide plan for youth. Just a few scattered information on things that we've done. So the first thing that we did, again, was to map out the different populations, where they are, how many there are. So we mapped out the different populations and sizes and concentrations of these venues. For street-involved youth, as an example, we tried to get information about what services they were accessing, what services they weren't accessing, where were the service gaps. So, for example, and one of the things that came out very clearly was that that STI services were really not widely available. Even at the youth-friendly clinic, they didn't have STI drugs. So it was sort of there were some real service gaps that were identified. We then have been working with the local government and the local NGOs on converting the mapping into interventions. So as an example, we'll take a map and we'll look at brothel-based sex workers, street-based sex workers, injecting drug users, street-affiliated youth, and come up with a coherent and specific plan for outreach to reach these populations. We've also used the mapping and the estimation of the population sizes to look at coverage and coverage by zone. So selecting which zones we're going to concentrate on. So we've done this for each of the groups, and we've developed a comprehensive package. So what is the package of services for the different groups? And so this is just an example of the clinical services that we've agreed on, along with the expected results for them. And then we've worked on developing a service configuration, so oriented around outreach teams, and then specifying how these outreach teams link these groups to various services. Again, starting with the assessment, developing the program standards and the program elements, and then developing the intervention plan. I'm going to finish by setting forth a few challenges and opportunities in program science, and then talking about what I think are some promising developments. First, I think that one of the challenges that we've seen in program science is getting coherent. So if you think about a framework that has assessment, assurance, and policy-related things, how do you assure or how do you achieve coherence amongst them? They should be integrated. So the assessment piece should be integrated with the assurance piece, and that should be integrated with the policy management piece. But quite often they go in different directions. So how can that be done? And I think that as your FOA starts rolling out, this is something that I'll be very interested in seeing, is how do you integrate what's happening with the assessment with what's happening with the assurance, and then how does that relate to the policy piece? Because if they're not integrated, then that whole package loses its strength. Because if they're, so you don't want to have an assessment that doesn't have a clear link to assurance and policy management. I think integration is another thing. So I think one of the things that I'm continuously reminded is that program science starts with programs, but it's not always easy to integrate scientists into that process. So, and we talked about that a little bit before, is how do you get scientists embedded within the process of programs? What is the right model for doing that? I think there's a fantastic opportunity with this FOA to see how will this work? How can we more effectively integrate science into the whole process of program planning and delivery? And there's always going to be knowledge gaps. And I think, as Bilal used to say, we're continuously setting sail while building the ship. You know, and we have to do that. That's public health, right? You don't have everything all sorted out before you start. You have to start. But then, how do we embed continuous learning into program implementation? How do we make sure that there's continuous mid-course corrections and those kinds of things? And I think that actually is related to where the integration of science into the program could help. If there could be good processes for doing that, we could develop some traditions whereby we're continuously learning from our programs as we go ahead. Some emerging ideas that I think could be helpful in the program science domain. One is the idea of building these program science platforms or learning sites, this idea of having purposeful partnerships between people who do research and people who do programs. Defining catchment areas and program objectives, so thinking about these partnerships in the context of an actual catchment area, and bringing in this iterative learning and doing. I think, as I was saying to Sebzi earlier, if you get 3 or 4 or 5 of these FOAs bringing up 3 or 4 or 5 really good examples of how this process works, that's going to be a huge step forward, because they'll be the vanguard for others. So if you see it working in 3 or 4 places, then I would say you really need to cherish and follow those groups and see what's working. And I think even reinvest in them to say, okay, this is starting to work really well, let's do more of this, because others will follow behind successful examples. And so I think that's going to be really important. We can't lose sight of capacity building. There's not that many people who really receive the kind of capacity building, focused, practical training in the program science process. I think we really need to get on the job with that and to think about practical training programs in some of these program science principles. And I think we need to strengthen our program science networks. As things are being learned in different contexts, in North America, in Europe, in other global domains, we need to build these networks so that we can accelerate innovation and we can also make sure that knowledge is translated quickly. I'm going to stop talking there, and thank you for your attention. Happy to entertain comments or questions or critiques.
Hi, Lizzie Cherney, Division of STD Prevention and Surveillance. Thank you for that great presentation. I'm a little in awe of all the data you were able to collect in Nigeria in that epidemic assessment. I wonder if you have a sense for how often it's necessary to do that level of data collection.
Okay, two things. First of all, the first time is always the most difficult time. So I think mounting something like this on this scale, the first time was difficult. It wasn't as difficult as we thought it was going to be, actually. It means you'd have to do a lot of training, have good modules and good supervision, those kinds of things. But I think that what we've learned is that once the program is going, if the program is at reasonable scale, then you don't have to repeat this so much. You can actually embed some of these processes into the program itself. So what we've done in other contexts where we started with a massive mapping and baseline assessments, what we do is then we integrate in updates into the program itself. So it's not, so the program every year or two will update its mapping. It doesn't start from ground zero. It takes its existing map and it says, are any of these dead spots, are there any new spots? So it's basically just updating some of those kinds of things. So for the mapping, we do updates every year or two, we update. And the programs themselves are continuously doing that. For the behavioral surveys, again, we actually embed that into the program, and we sort of say, okay, we'll provide you with technical support and some people, but we want you to get involved and help mobilize people. And every year or two, we'll do another behavioral survey. And we just do them as behavioral tracking surveys. You know, what's happening with behaviors, what's happening with economies, what's happening with other kinds of things. So I think the first time is much more difficult because you don't have a program context. Once you have programs in place, you can kind of embed and superimpose these things on top of the program. And that actually is part of the whole program science thing. If you can get programs to be continuously using this information, recollecting this kind of information, I think it really strengthens their engagement on this process. But I don't think I would redo this process de novo each time. I think I would just mostly do updates and fill in gaps and let the programs do that.
Hi there. Great presentation. So I'm a scientist who is currently working in the HIV program branch here at CDC. So last year we started a model where we gave funding to 30 grantees around the country to do program science work, where the spirit of it is you bring program folks, science folks together. So I'd be happy if that interests you at all to talk in more detail, but just to share a little bit about that experience so far. I think it's great. It takes a lot of effort. You know, your average program person and your average science person, they have different background training, vocabulary. Some of the maybe more obvious things are you want the program folks to appreciate evidence, standardization as much as possible. Sometimes that's not. And the science folks, like in our set of projects, we heartily welcome the researchers, the academicians, the scientists, but it's with the caveat of not to do research or hardcore science. It's bringing the scientists to help program first and foremost for program services. And yeah, you might get good data that can be published out of it. So I'm just very quickly letting you know there is a model that's new we're trying in HIV. Just a couple of my observations. So
I think those are exactly, that's been my experience too, is that it isn't always fun and games when you bring together scientists and program people, because they have different perspectives, they have different pressures, they have different incentives. All of these things are different. So in a way, I think you almost have to align at least the incentive around this. So, for example, one of the things we're trying to do in Canada is to come up with a funding model that isn't, researchers are funded to do this and programs are funded to do that, but to say, well, you together are jointly funded to do this. And so if you can bring together and align program funding along with science funding. So, for example, Canadian International Development Agency and the IDRC, which funds a lot of the research in developing countries, they're now thinking about focusing on certain countries and actually aligning their funding so that it's not a science stream and a program stream, but it's actually a coordinated stream. And I think that, but then then there's an incentive for academic institutions to get involved because there's money there, and they'll chase the money. But on the other hand, they have to come up with something that's a coordinated kind of a thing. But I think you're exactly right. I think it would be fantastic to hear the emerging experience. And I think we need to find opportunities whereby programs like yours can be shared with others. Because I know people in Canada are thirsty for getting information about how is this working, what are other people doing. They'd love to hear what's going on in this regard. So I think would love to follow up and get some more information about what your experience was.
And if you all are thinking about it as well, that could help us, probably either the STD or the HIV. Thank you.
Operator?
Yes, on the phone lines you may press *1 if you would like to ask a question. That's *1 for any questions.
Hi, Jill Hubbard from PDQIB. Thanks so much. It was a fabulous presentation, and Sevgi's heard my question before. Most of us are more familiar with evaluation, program evaluation, and quality improvement. How do you relate program science to program evaluation and program science? How do they fit together?
I didn't talk about it much here. I think that I think that quality improvement is really embedded within the actual conduct of a program. So I think embedding good process evaluations, but also good operations research within the context of a program has to be done more. So, program people are constantly making decisions about how to fine-tune their program. They're continuously making these kinds of decisions almost on the fly. This isn't working, that didn't work, or let's try this. But there's no sort of systematic way of both making those decisions, but also capturing what are those decisions and what was the result of those decisions. So I think one of the things, and I'm certainly not an expert in that area, but I think one of the things for this process of continuously improving quality of a program involves that making sure that you're continuously collecting the data and continuously analyzing the data from what you're doing, so that when you're making these decisions as you go along, you have a rationale for it, but you're also seeing what the consequences of your decision is going on. And that was actually one of the first things that Sevgi told me about when we were looking at this in India. She said, one of the things that seemed program science-y about our project there was that everybody at all levels of the project knew the data. They knew what they were achieving. They were measuring what they were doing. Now people, depending on what level, you're measuring different things. So field worker is measuring something different than, a district manager. But everybody was measuring something and it all fit together. And that I think is really important. So I think we need to embed much better processes for measuring and continuously looking at the stuff that we're measuring as we're going along. In terms of the overall evaluation of programs, I just think that we're just this far in terms of developing the methodologies for doing good impact evaluations. I think a lot of us are sort of saying we're skeptical about the potential value of our existing evaluation methodologies, like randomized controlled trials, but then what else? And so I think there's a whole science that needs to be emerging from that. And people are trying different things, but I think that does fit very much within the program science rubric. Is how can we develop better methodologies, both for the understanding the processes of quality improvement and also for the processes of evaluating and the impact of a program. I think it very much is embedded within the program science domain, for sure. Any questions on the phone?
I show no questions on the phone lines.
Thank you.